Hi there, my name is Kimia Manicherry, and I'm a second-year medical student at Schulich School of Medicine and Dentistry. Thank you so much for listening to my research presentation on my project titled Accuracy of Computed Tomography CT Imaging in Detecting Thyroid Cartilage Invasion in Laryngeal Squamous Cell Carcinoma. So to begin with an introduction, laryngeal cancer is a common malignancy of the head and neck, with the overwhelming majority of cases being squamous cell carcinomas, which I will abbreviate as SCC. Laryngeal SCC is divided into supraglottic, glottic, and subglottic subtypes, depending on the predominant location of the cancer. Globally, it has been estimated that almost 200,000 new cases were diagnosed and 100,000 new deaths were occurred in 2020 alone, according to the International Agency for Research on Cancer. And given that our elderly population represents the fastest growing subpopulation in North America and Europe, the proportion of patients with advanced laryngeal cancer will similarly continue to rise. And this further increases the relevance of research into a cancer that has the highest global incidence at the ages of 65 to 69 and the greatest prevalence around 60 to 80 years of age. The staging of laryngeal SCC has a direct impact on the ultimate management of the cancer, where the invasion of the outer cortex of thyroid cartilage indicates a T4 stage, generally requiring total laryngectomy. However, T3 staged cancers, where the tumor is confined to the larynx, but with vocal cord involvement or involvement of the inner cortex of the thyroid cartilage, are increasingly managed with organ-preserving methods such as chemotherapy and radiation, commonly abbreviated as CRT. The current methods for pre-therapeutic diagnosis and staging of laryngeal SCC consist mainly of computed tomography and magnetic resonance imaging, MRI, and the choice of modality depends largely on machine availability and the preference of radiologists at the center. So, despite the stark difference in management plans between T3 and T4 stage laryngeal SCC and how dependent staging is on imaging, there currently exists little consensus in the literature regarding which imaging modality is best suited for detecting thyroid cartilage invasion. And similarly, there's significant gaps in the literature about how accurate CT and MRI are in relation to the gold standard of postoperative pathological staging. And this is really important and leads to the purpose of this paper because underestimating thyroid cartilage invasion results in the potential for laryngeal cancer to go undertreated, and this could increase the risk of recurrence. But on the other side of the coin, overestimating thyroid cartilage invasion results in the overtreatment of patients with a total laryngectomy. So given the importance of reducing recurrence risk and the life-altering implications of total laryngectomy, it's imperative that thyroid cartilage invasion is accurately identified and is appropriately staged. The purpose of this study is therefore to assess the accuracy of computed tomography in preoperatively predicting thyroid cartilage invasion in laryngeal SCC as compared to pathological results postoperatively. Leading into the material and method section, our study design consisted of a retrospective review of 147 patient charts at LHSC. Charts considered initially were patients who had preoperative contrast-enhanced CT for suspected laryngeal masses from January 2009 through December 2019. We recorded patient characteristics such as their age, gender, primary site of their laryngeal SCC, and so on and so forth. Patients were included or excluded based on a set of criteria that I will get into in a second. And the eligible patients after that review were split into two groups. The first being patients who had primary laryngectomy with previously recorded T4 stage by head and neck radiologists. And we had 64 patients in this group. And B, patients without reported thyroid cartilage invasion and thus stage T3 who underwent laryngectomy anyways, and we had 38 patients in this group. Going into the inclusion and exclusion criteria, so patients included in the study were those who had laryngeal or hypopharyngeal SCC on histopathology, those post-2009, patients who had laryngectomy as their primary treatment, and those who had no prior head and neck surgery or radiation. And excluded were patients who had surgery more than 40 days after their CT scan, those that had incomplete patient records, and those who did not have mention on their pathology report of thyroid cartilage invasion. And more details on this pathway of the recruitment selection process is in figure 1, where you can see that we had, after this exclusion and inclusion criteria, 100 patients included and 44 cases excluded. In terms of CT imaging acquisition details, the results or the details of that are listed here with the type of scanners that patients were imaged with. So that consisted of the Canon Genesis 320 slice scanners and the Canon Aquilon Prime 80 scanners. And prior to late 2018, they were acquired using the General Electric 64 slice scanners and the 16 slice scanners. For histopathological evaluation, all pathology reports were reviewed and assessed for mention of thyroid cartilage invasion and the staging that the pathologist reported at that time. Thyroid cartilage invasion was marked as either invasion present or no invasion present. And in terms of the statistical analysis, we calculated the PPV, so positive predictive value, negative predictive value, specificity, and sensitivity of CT in detecting thyroid cartilage invasion compared to pathological post-operative specimen evaluations. Just before I move on to the results, another important thing to add on the CT aspect is that CT scans were marked as either thyroid cartilage invasion present or absent based on the report that the head and neck radiologist had in PowerChart. So moving on to the results, Table 1 outlines the patient and disease characteristics of the 100 eligible patients. And you can see that the age at diagnosis ranged from 48 to 91, and our average age was 66 years old. 80% male and 20% female patients, and the primary site of the laryngeal SCC is also outlined as supraglottic being the highest at 44%, glottic and hypopharyngeal coming next at 31% and 21%, and the least common subsite was subglottic at 4%. Table 2 outlines the clinico-pathological correlation of CT to post-operative pathology in detecting thyroid cartilage invasion. And so the PPV of CT scan was calculated to be 81.25%, and the NPV was calculated to be 66.67% for detection of any invasion through thyroid cartilage. The sensitivity and specificity were calculated to be 81.25 and 66.67% respectively. And then notably, not outlined here, but we had 19%, so 12 out of the 64 patients with clinical T4 disease that could have been downstage to T3 after pathology review and possibly offered organ preserving treatment. And on the other side, we had 33% of patients that had no evidence of thyroid cartilage invasion who underwent laryngectomy anyways, who were upstaged after pathology review. And moving on to the discussion. So the stark differences in management plans between T3 and T4 stage laryngeal SCCs underpins the importance of accurate staging and diagnosis for this patient population. The results of the study demonstrate that CT, as compared to the gold standard of postoperative pathology, is sensitive with an 81.25% sensitivity in detecting thyroid cartilage invasion. However, it is less specific at 66.67%. The PPV and NPV of CT in detecting thyroid cartilage invasion, as I mentioned before, was 81.25 and 66.67%. So therefore, CT appears to be more effective in correctly detecting thyroid cartilage invasion but less effective in determining the absence of thyroid cartilage invasion. And the study also revealed a crucial subset of patients that underwent a laryngectomy with preoperatively staged T4 disease, but were postoperatively found to not have thyroid cartilage invasion. And there's also a clinically significant proportion, 33%, who did not have clinically staged T4 disease who underwent this procedure anyways and were later found to have thyroid cartilage invasion. So there's currently little consensus on whether CT is the most accurate staging modality for laryngeal SCC and whether other methods might be more effective. For instance, it's been noted in the literature that CT offers a high spatial and temporal resolution for detecting thyroid cartilage invasion. However, it may be unable to distinguish between non-ossified cartilage and iodine-enhanced tumors due to similar attenuation values. And so there's many studies in the literature kind of that go against this claim and support it. But what we think is for next steps of this paper are to include having 2 blinded head and neck radiologists re-review all of the CT scans. But at this point, instead of just looking at whether the cartilage was invaded or not, also looking at a more detailed depiction of this, given minor invasion, major invasion, extralaryngeal spread, and ossification patterns, also commonly identified as sclerosis of the thyroid cartilage. And ossification is an important area of note for us at this time because it's noted to increase with age. And as I mentioned before, non-ossified cartilage has been shown to appear almost indistinguishable from tumors, and this may be relevant for the decreased specificity of CT in detecting the absence of thyroid cartilage invasion. So ultimately, identifying reasons for the overstaging of laryngeal cancer patients is crucial in ensuring that patients are offered organ-preserving approaches in lieu of the life-altering procedure of total laryngectomy. Oh, thank you so much for listening to my presentation. I'd like to also take the time to thank Dr. Danielle McNeil at the Department of Otolaryngology Head and Neck Surgery at LHSC for her continued support with my project. I'd also like to thank the Summer Research Training Program at Schulich School of Medicine and Dentistry for the funding and training in research. And yeah, thank you so much for listening. And if you have any questions, feel free to contact me at the email and number provided, and I'd be happy to chat and discuss the project in any way. And that's all. Thank you. Have a good day.